Well, hello, everybody. I have noon, and I think it's time to begin. Welcome again to all of you who are here today at our Overlake Circle of Excellence presentation. For those of you who I haven't met, my name is Molly Stearns, and I'm the Chief Development Officer here at Overlake Medical Center. In addition to our generous and loyal Circle of Excellence members who are here with us, and we're expecting over 32 of you today, we're also happy to welcome at this December presentation many of our corporate partners as well. These informational programs are just one way we can thank all of you for all you do for us in terms of supporting us and serving as our friends in the community. Today's presentation is going to focus on changes in the healthcare landscape. Like every other industry, we are seeing tremendous change, and I would argue probably greater change than some. And we want to talk about how Overlake is working to navigate through these changes as we continue to provide world-class care for our community. And nobody is better equipped to address this topic than our CEO, Mike Marsh. Most of you know Mike. And for those of you who don't, you'll soon, I'm sure you will meet him at some point. He's been at the helm here for almost 8 years and has served, prior to coming to Overlake, served in a variety of healthcare leadership positions in the Pacific Northwest over his long career of over 30 plus years. I think, Mike, we should start to say 35 years of healthcare leadership. Mike lives and breathes this topic, as will become obvious. I think he will also say it keeps him up at night periodically. But we're here to get into it. There's a lot to cover, and we'll get started. Just a few logistics. You guys are pros at virtual meetings by this time, but what we've done, we've placed you all on mute during Mike's comments, and there'll be plenty of time for questions. Thanks to those who sent in questions in advance. We've got those. We'll make sure they get that Mike responds to them if they're not covered in his presentation. Please feel free to raise your hand or come off mute with a live question or enter it into the chat, and we'll make sure that Mike sees those questions and he can answer them. Any technical difficulties, please call Gina in our foundation office at 425-688-5886. And other than I think we're done with the logistics, Mike. I'm going to turn it over to you. So thank you.
Okay, well, thanks, Molly. Molly, can you hear me?
We can hear you. I can hear you, yes.
Okay, great. Well, let me add my welcome to our Circle of Excellence donors and our corporate sponsors. And also happy holidays. Hope that you will find some time during this holiday season to rejuvenate with friends and family and to look at those things that you're grateful for during these very challenging times. I also want to thank you for your support. It is people like you and your companies that make Overlake the great organization that it's been for over 60 years, serving residents from the East Side and beyond. Molly already introduced me, so I won't say anything more about myself, but I can tell you that in my 36-year career in healthcare management, these last 8 years have been some of the most rewarding for me, and I feel very privileged to be able to lead an organization like Overlake. The purpose of the presentation today is for me to outline to you a few key imperatives that Overlake must be successful in addressing while we navigate this changing healthcare environment. I don't have any slides. I just really want to speak to you in a conversational way. I do encourage you, we had some pre-submitted questions, and so we'll get to those at the end. We also would look for you to put questions in the chat during my comments. So I won't stop to answer the questions during the presentation, but at the end of the presentation, Molly will serve as our MC to monitor and feed me the questions. And similarly, if you don't want to put something in the chat, feel free to raise your hand, and Molly will call on you at the end of the presentation. You know, my goals for today, in addition to most importantly thanking you, is to for you to understand these what are 5 imperatives. I'd like for you to understand a little bit on how the pandemic has affected these imperatives. And then most importantly, I guess I'd like for you to understand our response here at Overlake to these imperatives. So the first imperative is a shift from inpatient care to outpatient care. And before I say too much more about this, let me just kind of level set a little bit with these definitions. It may seem obvious, but there is some nuance. Without getting in the weeds, you know, you can think of outpatient care as care that is typically less than 24 hours. So an individual would be within some treatment protocol for less than 24 hours. It could be everything from an overnight stay that is less than 24 hours to an office visit that's less than 20 minutes. And inpatient care is, generally speaking, longer than 24 hours. Now, why that's important will become obvious in a minute. But it's also important to note that you can, generally speaking, provide outpatient care if you're a hospital. Overlake provides about 50% of our business is outpatient care. But you generally can't provide inpatient care if you're not a hospital. And so in addition to the hospital environment, like an organization like Overlake that provides both inpatient and outpatient, there are also organizations that provide only outpatient care. Ambulatory surgery centers would be a good example of that sort of a setting. And they oftentimes have different business imperatives that they're following that have influence on how Overlake thinks about its future. So let's talk about this shift. First of all, this shift has been going on for decades. So the 4 decades that I've been in healthcare, there's been a shift from inpatient care to outpatient care. So there's nothing new about that. However, with therapeutic advancements, patient preference, cost pressures, and yes, COVID, the shift is accelerating at warp speed. And so I'm going to use one example to sort of illustrate my point. The best example is total joint replacements. I suspect maybe 1 or 2 of you on this call has had a total joint replacement. And I'm talking about hips and knees. Well, historically, total joint replacements have been a major revenue source for hospitals and a significant revenue source for Overlake. In fact, about 15% of our revenue, 15% has come from total joint replacements. An average length of stay for a total joint replacement historically has been, and this is in the recent history, 3 to 4 days in a hospital. It's also worth noting that advocates have been for some time, and I mean a number of years, pushing for same-day total joint replacements for uncomplicated patients. And in fact, those advocates predicted to us old hospital guys and gals that it might be as much as 25 to 40% of the patients would be surgical candidates for same-day surgeries to replace a joint, come into the hospital, replace a joint, and be in your own home that same night. Well, it was very slow to evolve. Again, for the last, I'd say 5-6 years, this has been an ongoing topic of a risk to a hospital's traditional portfolio. Well, 2 things happened in this last year or 2 years. The first is in 2020, Medicare removed both hips and knees off the inpatient only list. Now, the inpatient only list is a list of procedures, I'm sure I'm wrong precisely, but directionally I'm correct, of about 300 procedures of cases that Medicare will only pay if they're done in an inpatient setting or a hospital setting, and there are 300 others. So in 2020, Medicare removed both hips and knees from an inpatient only. said differently, they now can be done in an outpatient facility. That could be an outpatient facility within a hospital, or it could be an outpatient facility in an ambulatory surgery center that has nothing to do with the hospital. The second thing that happened was COVID. And what happened with COVID, and you're going to hear a theme here, is patients became leery of spending time in hospitals. And so the idea of having a hip done safely in 1 day versus 4 days was very appealing. And so people who maybe were a little hesitant to think about a 1 day length of stay or a 12-hour length of stay in a hospital for a total joint, all of a sudden said, sign me up. So what are the implications of this to an organization like Overlake? Well, first of all, it introduces new competitors, and the ambulatory surgery centers unaffiliated with hospitals is the best example. And those new competitors are focusing on less complex commercially insured patients, leaving Medicare, Medicaid patients really to the hospital. So if you want to just bottom line it, it's fewer surgeries that are more complex and lower reimbursement to the hospital. And from a financial perspective, that's of course not a good equation to try to manage to. The second thing is, even for those surgeries that now are considered outpatient, but maybe still done here in the four walls of Overlake, outpatient procedures generally are paid at 30% less than inpatient procedures. However, these patients are still very complex. And so the intensity of care and the amount of resource to support a patient and get them safely discharged in 1 day versus 3 days, the cost of that, even though the reimbursement goes down by 30%, the cost doesn't go down by 30%. So as I said, previous estimates were this was going to be 25 to 40% of patients who were candidates for total joints being medically eligible. However, over the last couple of years in high-performing organizations, it's been actually over 90% of total joints are being discharged within 24 hours. So without a response, here at Overlake, this single example would cost tens of millions of dollars for Overlake out of our net revenue stream. But unfortunately, this is just one example. And in fact, last year, it was proposed and actually adopted for a period of time to phase out all of the procedures on the inpatient only list, every one of them, which would open the floodgates for similar dynamics to play out across multiple service lines. So you can imagine, again, when I gave you one comparison and then imagine 300 other examples and how that plays out. So what's our response been? So first, with respect to ortho, we immediately opened up something we call our rapid ortho unit, dedicated to acquiring the competencies for same-day total joints. And I'm pleased to report to you that we are a high-performing center. In fact, our numbers are that we discharge 97% of our total joints within 24 hours. 60% of our total joints are discharged within 12 hours. So part of our strategy, of course, is for us to provide a superior product, like I've just described, with great outcomes. It keeps the switching costs for potential competitors to compete successfully against that kind of product. In addition to that, it becomes a potential aggregator of care from large purchasers and payers. And a good example is Kaiser, who's on our campus or right across the street from our campus, who's looking to the kind of results and time frame that we're advancing to send many of their patients from across the region into our center. Second, when we think about the overall shift from inpatient to outpatient, we have purchased the majority interest in the Overlake Surgery Center. Now, the Overlake Surgery Center was a privately owned joint venture that Overlake had a minority interest in. It was primarily owned by independent physicians, but by us purchasing this in this last year, the majority interest in the surgery center that happens to bear our name and is on our campus, it just provides us with additional outpatient capacity for future The third thing we've done relative to this shift is we continue to build out the Overlake clinics. In my 8 years here at Overlake, we have had nearly a 5-fold increase in the number of employed physicians. Most recently, we brought on an independent urology group. And as of last week, we brought on an independent OBGYN group. And those two groups alone were 17 new providers and 90 new staff members. What does that do? It just, the urology group's a good example. They're a lot like orthopedics. In the old days, most of urology procedures were done on an inpatient basis. Today, most of the urology procedures are done on an outpatient basis. Now, those will be done within the Overlake portfolio, given the employment of this group of urologists. And the final thing we've done relative to this shift is we still continue to support those independent groups that have an alignment with us. And so we've created a platform through our electronic medical record, otherwise known as EPIC, called Community Connect. And just as one simple example, our first client which connects community providers and institutions to our electronic record, and otherwise known as, again, interoperability between records. One simple example of how powerful interoperability can be. An independent hospital up the road, Snoqualmie Valley Hospital, small critical access hospital, signed on to our instance of EPIC through Community Connect a year ago. And our referrals for their ED, for their emergency department, our increase in referrals from Snoqualmie Valley Hospital is up 800%. Now, while that seems unbelievable, the number to begin with was relatively small. So to be intellectually honest, I want to say we've gone up from about 30 to 35 referrals a year to now 250 a year. But nevertheless, you can see the power of interoperability, and we're rolling that out to other independent groups to create some form of connection to us. So the next imperative that I want to speak to is digital technology. So similar to the outpatient shift, the adoption of digital health is not new to healthcare. It's not a new topic. It's not something that hasn't been around for a long time. But even more than the shift from inpatient to outpatient, healthcare has been a very slow adopter. And a good example is telemedicine. Pre-pandemic, most health systems were very slow to implement a robust telemedicine platform. And then came the pandemic and healthcare hesitancy. And with hesitancy came the need for digital telemedicine because individuals didn't want to come into the office to be treated. And overnight, health systems across the country have, including Overlake, have deployed telemedicine platforms. But when we think about digital health and the imperative of digital health, telemedicine just scratches the surface. And my IT professionals and technology experts will laugh at my overgeneralization, but I'm going to overgeneralize here. And in general, when we think about digital strategies, they come in 3 flavors. The first is patient acquisition technology. So think about digital tools around cost and quality transparency, something that doesn't exist well in healthcare. Patient customization, something that doesn't exist well in healthcare, and care setting navigation. The second general category is care management. So you can think of home telemetry, monitoring a person's vitals from a remote distance instead of in a outpatient or inpatient environment, and or asynchronous visit platforms. And I hate to even use the term because it's kind of got a bad connotation, but you can think of chatbots, but think of them as chatbots that actually work, where they're helping people to navigate their aftercare visits in terms of managing their conditions or supporting them through chronic conditions. The third category is caregiver efficiency. So this is all about less paperwork, more care and less paperwork. An example of a digital strategy that's being deployed relative to that is ambient listening technology. to aid in clinical documentation so that providers are not spending so much time looking at a computer, but more time looking at their patients. So with digital acceleration comes digital disruptors, both large and small. So you can think of startups, or you can think of the giants like Amazon or Microsoft. But these are people that are working to provide digital solutions direct to consumers, cutting out traditional providers altogether. And the challenge with these disruptors is they're laser focused on profitable services. Remember, Overlake is a nonprofit organization. We care for anyone in the community, irrespective of their ability to pay. So I like to say that we care with the same level of technology and compassion for the woman that lives in her car who needs a heart procedure as we do for the woman that lives on Lake Washington who needs a heart procedure. But if you're in the realm of the disruptors looking for specific niche areas of profitable services that have helped to support the safety net for a hospital, a nonprofit hospital like Overlake, that becomes a threat to the traditional nonprofit delivery systems. So what's our response been? First of all, Overlake is an early adopter of Epic. Epic is the EMR that I referred to earlier. We've now been on Epic since 2013. Some of my board members, I think, are on this call today. You may not even know this number, but we've spent over $250 million on Epic in capital and operating expense over the last 8 to 9 years. It's a best-in-class platform, but it also has a lot of modules that are still capable of being optimized, which we're in the process of doing. The second thing we're doing, because we are living around so many tech giants who are interested in this space, is we're becoming connected to them in innovative ways, like Microsoft and Amazon, and creating selective partnerships with a small p, in the sense that they're not formal joint ventures, to look at ways that we can be an incubator for some of their technologies, just by virtue of where we sit in the ecosystem of the Puget Sound. And finally, and frankly most exciting, is we are launching a multi-year effort around digital acceleration, funded with tens of millions of dollars to address the best technology has to offer, both in patient experience and employee experience. And while this is not fully approved by the board, I think of this as the next phase of Project Future Care. Project Future Care was about a building. This is really about filling up the building with technology supporting the caregivers and the patients, and that is digitally oriented. We're calling it Project Steward. You'll hear a little bit more about this later. The next imperative is partnerships to aggregate care. So Overlake is looking to become a destination of care. It's hard to believe, but the East Side is now almost 1 million population. Now, for those of you that are longtime East Side residents, that I'm sure just seems impossible. But it's important to note that increasingly, kind of almost without any kind of fanfare, Overlake now has, depending upon the service line, between 20 and 25% of all of its care comes from outside of the East Side. So Central Washington, Kitsap Peninsula, Olympia, the West Side, you name it. So almost a quarter of our business now is coming from outside of the East Side. And so it's pretty simple. I mean, if we're going to have more and new competition, like I've just talked about earlier, for our existing market, which has historically been, from Renton to Kirkland to the mountains to the lake, we have to expand the definition of our market for complex elective cases like cancer and heart and neuro and bariatric, to other contiguous communities to our East Side. Like everything else, the pandemic was an accelerator to this too, because as COVID ebbed and flowed from county to county, you'd hear on news reports, one county was spiking while the other county was lowering its incidence, and you just heard this back and forth. People were looking for care who needed heart care, who needed cancer care, and they couldn't get it in their local communities. So this really accelerated the interest and the ability for people to actually depart from their local communities to look for best-in-class service. And some of that was promoted by COVID, just because they couldn't get the care in their local community. So what's our response been? Well, you know, some of this you've heard before, but there are some new really interesting things that we're doing. So, you know, we're doing partnerships, like our partnership with the Seattle Cancer Care Alliance to really keep care here on the east side, where the Cancer Care Alliance is really focusing on medical oncology and research, and we're focused here on our campus on procedural and diagnostic tests, so surgeries, procedures, diagnostics, testing in collaboration with the Alliance. Evergreen, you know, our partnership with Evergreen in neurosciences and cardiac is allowing us to really recruit some of the most highly subspecialized physicians in both of those service lines. And Kaiser, you know, we continue to have a strong relationship with Kaiser. Kaiser has recognized us as a center of excellence, both for structural heart and for bariatric care. And already we're starting to see a lot of patients from their other markets who are being funneled into Overlake. What else are we doing? Well, we're recruiting a lot of highly subspecialized physicians. We recently recruited a physician who is known as he wants to be known as a CCT interventional cardiologist. Some of us have been using the term CHIP, but CCT stands for Complex Coronary Therapeutics. It's a very highly subspecialized interventional cardiologist who can provide interventional services to individuals who otherwise wouldn't be candidates because they're too sick or their anatomy just wouldn't allow for it. We've hired a hepatobiliary surgeon who's working on very complex liver and pancreatic cases. Our foregut surgeon is coming in January to provide us with some of the most complex procedures for esophageal surgeries. A recently hired colorectal surgeon with some of the most advanced training in colorectal surgery. Similarly, a new breast surgeon with some particularly advanced training. New neurosurgeons, new thoracic surgeons, prostate surgeons coming with our acquisition of Washington Urology. So we're building our portfolio to really have the capacity to really meet the needs of any major medical center. You know, there are 112 hospitals in the state. Overlake is somewhere between the 5th and the 7th largest in terms of the size of our hospital. And we provide some of the most advanced care of any hospital in the state, and we will continue to do that. You know, when we partner with folks to aggregate care through this imperative, this is not about merging all the time. This is about creating a mutually beneficial relationship that incents them to send their patients. And this could be payers, it could be employers, it could be groups like Kaiser who both are a payer and a provider. But what they're looking for is they're looking to us to provide the highest level and quality experience and cost. And that's our part of the bargain. And the good news is our Project Future Care that we're coming around the bend on is well supported. We're well set up to support the capacity that this aggregation strategy, this aggregation imperative will enable us to do. The fourth imperative is the workforce shortage. And this is the most important. I mean, you talk to any hospital CEO, probably any CEO anywhere, under any industry, but certainly in the healthcare industry, it's number one, it's number two, it's number three. The labor shortage we are experiencing is historic. You get it again, similar to every other strategy, every other imperative I've talked about. There've always been shortages in healthcare and labor. My entire career, nothing has ever come close to the shortages healthcare is experiencing right now across the entirety of the platform. It's in all job classifications, but it's particularly dramatic in highly subspecialized nursing positions like our ICU, telemetry section, our emergency department, some of our surgical areas. So it's multifaceted. Number one, burnout. COVID has, we were one of the first 3 hospitals in the state to start seeing COVID patients. Prov Everett was number 1, and then on the same day, both Evergreen and us started seeing patients. So we've been on the front lines from the very beginning, caring for COVID patients. It has really taxed the organization because it's had so many different implications along the way. The second things that we face here in this market that maybe some other markets don't face is our high cost of living and the housing boom, frankly. So you have a nurse that is burnt out, and all of a sudden she has $600,000, or he has $600,000 of equity in their home that they never thought they would have beyond because of the housing boom. And they look to move to Central Washington or Idaho or some other place with a much lower cost of living and have this windfall coming from the environment. And then recruiting people into this incredibly high cost of living is a challenge. And finally, just mental health and wellness of our providers. Our FMLA, or family medical leaves, are up over 50%. And that's because people are taking care of elderly parents, they're taking care of their children who don't have a classroom to go to, or they're just taking care of their own mental health. Right now, just to give you a couple of other stats, our open positions are 2.5 times the highest that they've ever been. And our turnover rate at times has reached nearly 30%. So how do you run a business when you're in a situation like that? Well, you hire what's called premium labor, or these are nurses or other technical staff that come from agencies that charge you a king's ransom in order to show up on your doorstep and try to meet the needs of your patients. Well, that just further exacerbates the problem, because not only does that further strain your finances, but it demoralizes the staff that is remaining, on the front line, because they have a new nurse who's just joined, who's an itinerant nurse, and who's making 3 times the salary that your existing nurse is. And yet at the same time, we have to meet the needs of the patients who are here, who expect us to care for them. By the way, these are highly trained nurses. These are not nurses that you wouldn't want your father or your husband or wife to have take care of them, but they're very expensive and they do create cultural disruption. So what have we done? You might have read in the Puget Sound Business Journal that we have been one of the bolder hospitals in making some near-term investments. We've invested about $23 million in retention bonuses and increasing our minimum wage to $20 an hour for our lower paid workers. We've created a whole new tier of nuisance supervisors to support the span of control. We've created new residencies and apprenticeships and career ladder programs to support sign-on and referral bonuses, new recruitment resources, top of license resources to help providers, again, focus on care by creating new positions. And also, I don't want to forget the fact that the generosity of one of our donors helped us double our tuition reimbursement program. So good news is we're starting to see improvement. We really have seen some immediate benefit from those investments. And both October and November, we saw a lot of our turnover rates. We are having now record number of hires. We're on track to hire about 1,000 people this year. So in addition to near-term money, culture is everything. And it really is one area that Overlake can be a differentiator. Because we're not part of a large multi-state system, we pride ourselves in creating a culture where everyone has the opportunity to make Overlake better. This is not an orders from a headquarters type of a place. This is an organization that if you come to work at Overlake, we want you to speak your voice. We want your ideas, and we want your energy to make this a better place. That's appealing to a lot of people. So that does provide us with, I think, a unique differentiator. And then again, most exciting, I think, is this multi-year people plan that we're developing that is nested in what I previously referred to as Project Steward. So again, you can think of it as an extension of Project Future Care, whereby Future Care is a building and Steward is about the people and about the technology, and especially digital technology. So, I mean, the punchline is if you, in my view, if you become the employer of choice in this epic labor shortage that's not going to go away anytime soon, you win. I mean, forget every other strategy I just talked about. If you do that well, you win. So we're spending a huge amount of time. The final imperative is delivering a high quality, safe, and patient experience. What's that? That's our product. That's why we're here. Now, that might sound obvious, but making investments with fewer resources and continuing to deliver a great product is an extraordinary challenge. I was on a board meeting. I serve on a board, and the CEO of that company yesterday gave a great analogy I want to share with you. He was talking about how professional pool players, when they get really good, they can start to predict not just the shot that they're making, the first shot that they're making, but they can start to predict where the second shot's going to be, where the third shot's going to be, and where the fourth shot's going to be. But sometimes they're so focused on the second shot and the third shot and the fourth shot that they miss the first shot. We can't miss the first shot. So in terms of the financial effect and the staffing crisis of COVID, I'm not sure Overlake's fared much better or worse than others. The pandemic has been devastating on the finances in the healthcare industry. I know that for some people that's actually news. It's surprising to me, but especially for the hospital environment. And then, of course, I've talked about the staffing crisis. I think you're well aware of that. However, from a high quality, safe patient experience standpoint, Overlake has bucked the trend. So during the whole pandemic, many hospitals, for reasons that you would probably appreciate and understand, their quality and safety scores have decreased during COVID. In fact, one industry expert predicted that the pandemic has taken the entire hospital industry back 10 years in its quest for patient safety. At Overlake, our quality and safety scores have improved during the pandemic, or stayed the same. An example is the Washington State Hospital Association puts out a dashboard every month of all hospitals, but I look at just the large hospitals. There are 39 large hospitals across Oregon, Washington, and Alaska that are listed in this database. And there are a whole host of patient safety indicators. Overlake is in the top tier, 25% on every single patient indicator, maybe except for one. In most cases, Overlake is at top either number 1, number 2, number 3, number 4, number 5 out of 39 hospitals in terms of safety. That's during the pandemic. In addition to that, the staffing crisis especially has had a negative effect on patient experience. You can imagine if you have less staff, the likelihood that you're going to have a good patient experience is probably going to be affected. Well, I'm really super proud of this team because even though in some cases we've seen a deterioration in our scores, relative to others, we still maintain top performance. So 2 examples, we have been in during the staffing crisis in many cases in what we call black or red surge status, which just means you're overwhelmed. And yet, in spite of that, we've been in the 90th percentile for our emergency department in terms of patient experience, and the 96th percentile for our hospital, for large hospitals across the country. And our clinics are in a cohort of 10 across the state of large multi-specialty clinics. And again, during this pandemic, they're currently at number 1 in that cohort. So while financially and from a staffing standpoint, I think we were right in with the pack as it relates to the challenges of COVID to deliver on this imperative. We are delivering on this imperative. And the competency of the focused discipline to not miss the first shot, I think, is an important testament to our ability to both plan for the future while we deliver in the present, even if the present is a pandemic. So I'm going to stop there, and I'm going to ask Molly. I actually stopped right on time, which is unbelievable for me. So I'm going to turn it over to Molly to MC the Q&A.
Well, that was that. Thank you, Mike. Thank you. I work here and I learned a lot just in the last 40 minutes. So thank you very, very much. So while we wait for questions to come into the chat, or if we look for some hands to come up, or as you put, or just take yourself off mic if you would prefer, there are a couple questions that you didn't answer during that presentation that I would, let's just start, I'll pose to you now. The first has to do with future initiatives for us in our behavioral health service line. Is Overlake looking to develop or build out any additional services to what we're currently offering, and just restate what we're currently offering in that service line? Sure.
So I say this often, one thing I hope our community is proud of is that since our beginning in 1960, Overlake has always been committed to serving patients who are challenged with behavioral health conditions. That's quite a legacy to uphold, and we continue to do that. I'm really thrilled to announce that we just opened our new psychiatric hospital in November as part of Project Future Care, so that will continue to advance our commitment to those patients. We just recently on our campus, while Overlake doesn't run it, we do have a strong relationship on our campus and have encouraged them to be here with the largest eating recovery center west of Denver. So again, supporting that patient population. In addition to that, Betty Ford Hazelton is on our campus supporting people with addiction disease. And many of you know that we also run a school for children who are behaviorally challenged. As we were planning for the build out of our new center, we added a service in supporting patients who have co-occurring disorders, or what some people call dual diagnosis. These are behavioral health, mental health patients who also have an addiction diagnosis. So we're now treating those patients. In the future, we do have a license. We have 14 beds in our inpatient unit. We are a fully integrated behavioral health service too. It's not only that we have inpatient, but we have intensive, we have inpatient, we have partial hospitalization, we have intensive outpatient, and we have outpatient. So we have the full continuum of care. Within our inpatient unit only, we have 14 beds. We have a license to go up to 38 beds. And the way we build out the space, we have the capacity to expand into some of those beds. And if I had my favorite, only because I have, if I had my druthers is a better way to put it, one of the first things out of the chute would be a focus on geriatric psychiatry and working on geriatric psychiatry. So,
Steve Brooks just threw a question into the chat, and it's somewhat. I will also get to the one that you actually sent in, but let's start. Mike, what he's asking is, how do you make the market aware of the successes? He's congratulating us on the successes of the rapid ortho team and patient success and satisfaction to draw them to the hospital and clinics. And in other words, how are we going to be able to market that in our good quality and outcomes so that we can increase our work in that area?
Well, Steve, that is a really great question. And in fact, my staff has heard me say this more times than I'm sure they appreciate. But when I do presentations like this, and when I used to do them in person, I would have people come up to me after the presentation, and the comment that I would get most frequently is, "I had no idea. I had no idea that Overlake was doing those things." And I don't like being the best kept secret. I don't think that's a great thing to aspire to. So, we have really worked hard, and I think we've done a lot in the last few years to up our game on earned media. So really creating human interest stories and getting our profile out in the public. But we've certainly done a lot relative to social media. We've made some big investments and made some great strides in reputation management across social media. But we don't sponsor the Kraken, and we're not on primetime television, and so there's a lot about our profile that still is a little understated. Part of what we did, I mentioned 2 of the 3 legs of Project Steward. Digital acceleration is number 1, and then the second is people plan, right? Well, the third part is brand awareness. So the third part of what you're talking about, Steve, is let's stop being the best kept secret. And that's what, and so part of that investment that we're making over 5 years, that is a board-driven strategy, is got that leg of the stool.
Great. And the other question that Steve had that you didn't answer about our positioning and how we're going to be building out to better continue to serve our communities is, what support do we need to lead this effort? What support do you need to lead this effort to make sure that we're successful? And what are the biggest constraints?
The biggest constraints is going to be staff. I mean, that there's no question that if we can crest the mountain on this epic staffing crisis, that will enable us to achieve the imperatives. If we can't, it will be an encumbrance to achieving the imperatives. Steve, what I like about your question is it gives me the opportunity to say Overlake was built for the people and by the people. And I mean that. I mean, if you know the history of Overlake, it's an impressive history. Like I said, I've spent 36 years in healthcare, and I love telling the Overlake story. And it's about people who recognize that you will never have a world-class community without a world-class hospital. Not just a community hospital. I mean, I always sort of bristle at the term community hospital because it understates the subspecialization of what we provide here. But certainly we do serve our community, and that's important. And that not just important, it's essential. But what we need from you really is active engagement in things like this, and enthusiasm for supporting us. Project Future Care was a $270 million project. Donors contributed $50 million of that $270 million. That wasn't just people writing checks. That was people having house parties and participating in events and getting interest in their businesses to support this institution that is somewhat unique. We're now only one of 3 501c3 hospitals in the state that's remaining out of 112 that is not part of a large health system, not tax supported, or not a critical access hospital. And yet we're still thriving in that environment. Thriving maybe is a bit of an overstatement in this era of COVID, but we are still we have a very sustainable platform and vision for the future. But I don't think that everybody totally realize how tough the sledding is for healthcare and hospitals in general, based on some of those imperatives that I just talked about. And as we enter this era, having community engagement will also be a difference maker.
Yeah. Well, and as the head of development, Steve, I want to thank you for that tee up because Mike said it extremely well, the importance of community support. So another shifting topics, a question about the increased difficulty for seniors who are confined to Medicare coverage finding quality primary health care. Any, in particular, as the donor, as this member is stating, as some of the good insurance companies are bowing out of Medicare insurance involvement.
Well, I think you mean good physicians, not good insurance companies.
Okay. Yeah.
And I'm not sure I would totally agree with the assertion, but I do understand the point. And the point that the person who's asking the question is making is exactly the point I was trying to make, is that if you're optimizing your business model, you're going to want commercial patients. You're not going to want patients who are Medicare and Medicaid. And so that then means you may have more and more physicians who are looking at trying to make ends meet by saying, I'm not going to see Medicare patients because the amount Medicare pays is not enough for me to cover my costs. Mm-hmm. And a physician has the ability to do that in independent practice. A nonprofit hospital does not have the ability to do that. We see everyone. And so the good news, so that underscores the point that I was trying to make around the challenge of that tension between commercial and government payers. But the good news is Overlake has a lot of primary care doctors that will see you. And in fact, as I said, we've increased by the end of this year, 2022, so calendar year 2022, we will probably have increased the size of our network since I've arrived, just in the 8 years that I've been here, from about 60 providers to, and these are not all primary care providers. Many of them are specialists, to about 300, almost 300, with all of the forecasted acquisitions and recruitments, et cetera. So I did see this question before, so I reached out to our chief operating officer of the clinics, and last year alone we recruited 20, nearly 20. I think it was 19, and we have a number of new primary care physicians in the pipeline. They accept Medicare, and they're good. They're very good. We're actually drawing some outstanding primary care physicians, and I'm sure that Molly would be very happy to link you up with any number of them.
Absolutely. Mike, the other questions that were posed, you really covered very, very well about new technologies coming to Overlake and growth strategies around building out to serve our growing population. I think, and I'm not seeing anything else in the chat, so thank you. And again, it was very informative. And thanks to all of you who joined us. It was, again, it's providing information like this is, again, one way we can thank you for all you do for us, and we appreciate it. We will be shortly sending you a survey that we hope you will complete and get back to us. We really want to make sure that we're covering topics that continue to be of interest to you. So please give us your thoughts on future presentations that we can put together for you. Our next presentation that is already planned will be on February 4th, and it will be, the presenters will be Dr. Ron Aviles, who was one of the pioneers of in our cardiology area around our TAVR program, and Dr. Rob Riley, who Mike referenced earlier, we've just recruited to help build out the complex coronary therapeutics program, and they'll be talking in general about our overall structural heart program, which really is one of those specialties that we would say is best in class. So mark your calendars, and you'll obviously be receiving more on that. So thank you again, all. Happy holidays, and take care.
Happy holidays. Thank you.
Thank you so much.